Endocrine vignettes on Step 2 CK are specifically designed to disorient you. They present a web of overlapping, ambiguous systemic symptoms that draw your attention away from the localized root pathology. A patient presents with lethargy, weight loss, severe diarrhea, and muscle weakness. You could be looking at an infection, an autoimmune disease, or a malignancy. To solve these cases, you must apply a mandatory two-step diagnostic algorithm. Step 1 is biochemical confirmation. Step 2 is anatomical localization. You cannot reverse this order. Vague symptoms must first be isolated to a specific hormonal axis via targeted functional testing. Only after the lab values confirm the chemical excess do you proceed to the scanner. Mastering this strict operational sequence is the only reliable way to cut through clinical noise and prevent the trap of premature imaging. We see this logic clearly in the gastrointestinal axis. Neuroendocrine tumors located deep in the pancreas routinely cause massive downstream disruptions in the gut. A VIPoma presents with a specific triad: massive watery secretory diarrhea, profound hypokalemia, and achlorhydria. Because of that specific symptom cluster, the first move is measuring vasoactive intestinal peptide levels. Once labs confirm a VIP level over 75 picograms per milliliter, you secure an abdominal CT or MRI, typically locating the mast and the pancreatic tail. Zollinger-Ellison syndrome requires a similar approach, but with a different chemical signature. Suspect ZES when you see peptic ulcers that are refractory to treatment, or ulcers located unusually far into the distal tract, like the jejunum. Unlike VIPoma, ZES tumors release massive gastrin, plummeting intestinal pH. This inactivates pancreatic enzymes, blocking fat emulsification and causing steatorrhea. Diagnose by checking gastric pH and gastrin off PPI therapy. High gastrin and low pH confirm it. Intermediate levels require a secretin stimulation test. In both of these neuroendocrine GI tumors, the downstream chemical effect dictates the exact biochemical test you order before you ever look at the pancreas. But there is a vital caveat. 80% of Zollinger-Ellison cases are sporadic. The remaining 20% are intrinsically linked to multiple endocrine neoplasia type 1. MEN1 is defined by the 3 Ps: pancreatic neuroendocrine tumors, pituitary adenomas, and primary hyperparathyroidism. This hyperparathyroidism is the most common manifestation, present in over 90% of patients, typically presenting clinically as elevated serum calcium and kidney stones. Identifying a rare neuroendocrine tumor is an automatic mandate. You must immediately initiate a clinical hunt for the other 2 MEN1 pathologies to complete the diagnostic picture. To differentiate catecholamine-secreting tumors in the adrenal and sympathetic axis, the diagnostic path begins with the patient's age. A neuroblastoma occurs almost exclusively in children under 2 years old. It originates from the neural crest cells or the sympathetic chain. The physical exam will reveal a palpable abdominal mass. Depending on the tumor's location, you will also see periorbital ecchymoses, often called raccoon eyes, from orbital metastases, or Horner syndrome from cervical involvement. Neuroblastoma proof requires elevated catecholamine metabolites, NY-MYC amplification, and small round blue cells. Compare this to adult pheochromocytoma in the adrenal medulla. It presents with a classic triad: episodic headache, sweating, and tachycardia, driven by paroxysmal hypertension. The diagnostic rule here is absolute. You must confirm elevated plasma or urine fractionated metanephrines before you order an abdominal CT or MRI. Once the tumor is found, surgical resection is required. But to prevent a lethal hypertensive crisis during intubation, you must administer alpha receptor blockade prior to beta receptor blockade. While both masses overproduce catecholamines, the patient's age and distinct genetic markers separate their exact diagnostic and management logic. Moving to the thyroid axis, the primary initial staging tool for suspected thyroid cancer is always an ultrasound of the neck and cervical lymph nodes. Tumor size dictates the surgical approach. A papillary thyroid tumor under 1 centimeter is managed with a thyroid lobectomy. Anything over 1 centimeter, or any tumor showing extrathyroidal extension, requires a total thyroidectomy. You also have to monitor for drug toxicity. If a hyperthyroid patient taking PTU or methimazole suddenly develops a fever and a sore throat, you must immediately suspect a granulocytosis. In pediatric thyroid emergencies, the exact timing of symptom onset reveals the underlying maternal-fetal pathophysiology. In neonatal thyrotoxicosis, maternal anti-TSH receptor antibodies cross the placenta, binding directly to infant receptors. This causes immediate tachycardia, irritability, and poor feeding. The condition is transient, self-resolving within 3 months as the maternal IgG naturally clears. Congenital hypothyroidism presents with the opposite timeline. Because these infants are temporarily protected by maternal thyroid hormone, they appear completely asymptomatic at birth. The pathology only reveals itself weeks or months later as the maternal T4 wanes. The infant develops lethargy, poor feeding, an enlarged fontanelle, and prolonged jaundice. This is a medical emergency requiring immediate levothyroxine to prevent severe neurodevelopmental injury. In neonatal thyroid pathology, the presence or absence of maternal hormones dictates a strict timeline that separates a self-resolving issue from a permanent developmental threat. We can now merge these isolated axes into a single, highly reliable framework for test A. Trace the GI logic. Massive secretory diarrhea requires VIP levels. Refractory or distal ulcers require gastrin and pH testing, alongside a high clinical suspicion for MEN1. Trace the adrenal logic. Episodic hypertension requires elevated metanephrines prior to imaging. An adrenal mass in a toddler requires NYC amplification testing. Trace the neonatal logic. Immediate jitteriness points to transplacental Graves antibodies. Delayed lethargy points to congenital hypothyroidism and the need for instant hormone replacement. This diagnostic sequence forces ambiguous clinical data into a predictable framework. Biochemistry dictates the diagnosis. Anatomy dictates the surgery. Trusting this specific sequence is how you analyze the symptoms and secure the correct answer.